Good morning, everyone. It is my distinct honor to introduce Dr. Marina Tolou-Shams. Dr. Tolou-Shams did her undergraduate degree at UC San Diego, her master's and PhD at University of Illinois at Chicago, postdoctoral fellowships at Brown and clinical psychology internships, and then went on to be faculty both at Brown and now is the Kilroy Realty Endowed Professor in the Department of Psychiatry and Behavioral Sciences at UCSF, where she's also Vice Chair for Community Engagement, Outreach, and Advocacy, a professor and Deputy Vice Chair for Research. Dr. Tolou-Shams has been doing substance use, mental health, and HIV prevention research since 1998, working with ethnically, racially minoritized populations, sexual minority youth, youth in inner cities, and youth involved in systems. She's been continuously funded since 2007 by NIH, and her research incorporates behavioral intervention, efficacy trials, epidemiological, observational health services, and health disparities approaches to understanding how to improve substance use, mental health, and sexual health outcomes. A colleague and I were Googling Dr. Tolou-Shams, and we realized that she is the most funded juvenile legal system behavioral health researcher in the galaxy. And she's been just the mightiest of mentors. She has numerous grants. One of the most impressive is for the past 17 years, she's mentored close to 50 trainees of various disciplines and backgrounds, many of whom are in academic research positions, and over 60% of these are underrepresented in medicine. On a personal note, Dr. Tolou-Shams is really emblematic of an equity and justice scientist, not only in terms of her scholarship, but in also how she lives as she climbs. She consciously cultivates collaboration and understands the fierce urgency of now in addressing inequity in all forms and on all fronts. So she is simply goals.
Thank you so much. I have a lot to live up to from such a generous introduction. And I'm so grateful and honored to be invited to come be with colleagues who I'm so excited. Some are in the room and all of those of you on Zoom. It's really my pleasure. And one little piece that Dr. Bath left out was actually how we connected back in 2015. This was back when people had landlines in their offices. Remember those days? Yes. And I literally just been recruited to UC San Francisco from Brown. I'm from the Bay Area originally. And the phone rang. I picked it up. Hi, this is Dr. Erica Bath. Hi, Dr. Bath. You know, and I'm still at the place where I'm trying to find the restroom in the building at San Francisco General Hospital. And she says, I'm submitting a grant in the area of CSEC, substance use, and sexual and reproductive health, and you're one of the only people in the state who's doing this work. And now I was newly in California, and I thought, my people, like it was amazing. And then of course, it has been the biggest blessing to have the opportunity to continue to work with her colleagues, and all of our colleagues at UCLA, who I'm so excited to continue to grow with and work with. So I'm going to talk today about building pathways to prevention and next generation strategies for reducing substance use among systems impacted youth. And I have no disclosures or conflicts of interest to report. This work takes a community. It takes not just our funders, who are quite generous, National Institute on Drug Abuse, National Institute of Mental Health, all of the foundations, and our partners in technology, which I'm going to talk a little bit about, also our city and county colleagues. And the last person I have on here, I'll talk a little bit when I just mentioned about my positionality in this work, Bruce Green, who was my high school English teacher in El Cerrito, California. And of course, all of the youth, young adults, and families who give their time to allow us to do this work. This is our team, the Juvenile and Justice Behavioral Health team based at San Francisco General Hospital. And one of the projects I'm going to talk about today is called EPIC 2. And this is our team of investigators. And this is team science work. This is community. We were talking earlier about it's a love circle in terms of the generosity, love, time. Everyone commits to this work. And it is critical. We have a criminologist from UC Berkeley, Erin Carrison, Joanna Folk, who's a child clinical psychologist, myself, we have Akila Dulin-Kita, who was at Brown, is now at Tulane, is a medical sociologist, we have an epidemiologist, and we have a child psychiatrist. That is what is necessary, right, to do this kind of work well. And I position myself intentionally in the middle because I am learning and growing from our team. So before I get to the pathway for today, I just want to take maybe 30 seconds, given our timing, to talk a bit about my positionality in this work. So I mentioned to you, I grew up in the Bay Area. I immigrated to the Bay Area in '79. I am Iranian, and I am not a US citizen. I'm very regretful for this election in particular that I am not. My parents are not either. I'm an only child. I have 2 daughters of my own who are teenagers. And I have various layers of privilege. I have skin color privilege. I have class privilege. I have education privilege. I have financial privilege. And the reason I put my high school English teacher on this list was because when I was 15 years old, he assigned a project called the iSearch, where we had to ask a question about something we were very curious and answer about. It was my first scientific exploration, basically. We had to go out there and start doing qualitative interviews, reading. And my question was, how could anybody be an executioner? So that might give you a little window into me, but I couldn't understand how someone could willfully put someone else to death. And I'm happy to talk more about that story, about what happened. But ultimately, I ended up doing a qualitative interview at Zachary's Pizza, for those of you who are familiar with the East Bay, that's still there, with a man who used to be on death row, who generously gave his time to me and sat across the table from me, eating our dinner. And I had non-digital audio recorder. And he so generously shared his entire childhood and upbringing. And from that moment, I didn't know if I was into legal, social work, whatnot, but I just knew I wanted to do something to think about how we keep young people out of the system by building capacity in their communities. So that's, I'm happy to share more about that later. So the pathway for today is going to be to talk a little bit about background, the US juvenile legal system, unmet behavioral health needs of youth in the system, our approach in the lab from the macro. We have a project that's looking at structural racism, and to the micro, right? We're talking about participatory co-design, working and co-creating with those with living experience, and going from assessment to intervention. And I'm going to talk about some very preliminary, these are hot off the press, so I'm really excited to talk with folks about it after, about thoughts for these analyses. And then talk a little bit about a current project building and testing system pathways to prevention with foster youth who have court-appointed special advocates. And I'll talk about that more. And I hope that you might invite me back in another year or two where I can actually talk about the findings for this project that we're embarking on. Just some definitions. When we're talking about systems impacted youth, we're talking about adolescents and young adults through age 26 who've had some type of contact with the juvenile legal or child welfare systems. Juvenile legal system could refer to family court, diversion, probation, detention, all along the various intercepts of contact. When I say YLS, or you see that in the slides, it's youth in contact with the legal system. And then in and out of home placement, both are court-involved youth, right? But one is actually ordered to be placed out of the home and considered foster youth. And could be kinship care, which I don't also have on here, but that means a family member is taking care of the young person when they are removed from their family of origin. And then behavioral health. So I'm referring to mental health, substance use, and or sexual and reproductive health. Today, I'm really going to focus on substance use prevention largely. Okay, for those who aren't in the juvenile legal and forensic space, the US is in the 4th wave of juvenile justice reform, right? So 1899, the first juvenile court opened in Cook County. Then we went to In re Galt in 67, where youth were finally having due process. And then the pendulum swung the other way in the late 80s and 90s with the super predator theory. And young people and young Black and brown people in particular were incarcerated at much higher rates. And we had all of the war on drugs, which was highly, highly unsuccessful. We could have a whole another conversation about how history continues to repeat itself. It's very relevant right now with our drug crisis and fentanyl and opioids. But now the US is in the fourth wave of juvenile justice reform. And why this is important for this kind of work is because I think there is an opportunity where the fourth wave is really listening to the developmental science around brain development and behavioral outcomes for young people, thinking about that. There's a huge emphasis now on diversion. When I first started this work, and one of these projects you're going to hear about, diversion was very nascent when we're talking really like early 2000s. And there is a greater emphasis in growing body work, so much work to be done that's going on in this department too around trauma-informed juvenile justice systems. And I think we might argue that putting trauma-informed and juvenile justice in the same sentence may not actually work. We may need to be thinking about disrupting in other ways too. So this is why it's an opportune time, I think, to think about this macro level work that I'm going to talk to you about today. Despite this, we're still locking up young people at really high rates in this country. I was just in Sao Paulo, Brazil. They were shocked to see the numbers, and we are incarcerating young people at higher rates than Sao Paulo. Ukraine done work there too. So we have a tremendous amount of work to do in this space. And of course, we still see huge disparities in terms of who is getting detained. You see rates going down, or you're going to hear people say, oh, diversion works, diversion works. Well, and clearly here we see in the top right corner that Black and American Indian and Hispanic youth are being detained at much higher rates, with Black youth dramatically above the other young people. And the map on the left is just showing kind of the youth residential placement rates by state. And so you can see California is kind of in the, it's not in the lowest. So we are not doing great in terms of residential placement rates and detention. Okay, so why is it important for us to think about behavioral health, mental health, substance use prevention? Because actually what we know is that among a sample of young people in the community who we assessed, who were referred for a court clinic evaluation. So these are those which the judge is already flagging to say, I need help to understand about making recommendations for this young person. After accounting for all the relevant demographics, age, gender, race, ethnicity, legal history, and other psychiatric factors, those young people in contact with the legal system who had a co-occurring psychiatric and substance use diagnosis were 6 times more likely than their non-dually diagnosed peers to have been detained over the 12-month follow-up period. So we have an opportunity to interrupt that trajectory in various different ways, but certainly in terms of providing intervention at the front door. And then if we look at gender differences in recidivism rates, we see that for girls, if we're looking 12 months out from first-time contact with the court, girls who have a history of sexual abuse, right? So relevant to Dr. Bass' work and others' work, it's precipitously higher, their likelihood of recidivism at 12 months in detention. So if I haven't convinced you already about why youth at first-time court contact, those data are pretty compelling, right? There have been studies that have looked at primary prevention, the Pittsburgh Youth Study, right? And preventing even first-time touch with the system. There have been studies that have looked at tertiary prevention of system involvement for what they describe in this study, pathways to desistance, as serious violent offenders. But when we put in the application for Project EPIC, it was the first study of its kind to do a longitudinal assessment study of young people in first-time contact with the legal system. So they had to be within 30 days of coming into contact within one particular state, which I'm going to talk about today. So you see here, Project EPIC kind of fills that gap. right, of the initial court appearance. This sequential intercept model that has initial detention and court hearings, the youth who were in Project EPIC were not detained. That was actually, the idea was to get them while they're in the community to understand the trajectories with one youth and an involved caregiver. So what did the Project EPIC sample look like? These data the project ran from 2013 to 2018, and the baseline data were collected from 2014 to 2016. And what you can see here is that the disproportionality was here in the sample, and it was this is a statewide sample in the Northeast. And the Black, African-American, or Haitian category was double what the current census was in that state and in that urban core. And I'm going to show you a map of this as well when we talk about the structural racism index. And the same was true for Latin. The census at that time was 22% Latin in the state. You see high rates of public assistance and also high rates of educational need through IEP, 40%. And we also see similar high rates of psychiatric need and trauma, 78%. So the one thing, I'm sorry, I didn't talk about here or point out is that 14.5 years of age was the average age of our sample when they came into first-time contact with the court. The range was 12 to 18. 50% came in with a first-time status petition, which meant it was an illicit activity just by virtue of being under 18, alcohol, curfew, breaking curfew, truancy. So the largest proportion of our status youth, if you will, 50% of the sample, were in truancy court in the state. The other 50% ranged from larceny, assault, drug-related charges, and 78% of them endorsed at least one lifetime traumatic exposure at age 14.5. They had an average of 3 ACEs, adverse childhood experiences, and really high rates of lifetime suicidal ideation and attempt. And one of my mentees who is there now has been doing really amazing suicide prevention work at the front door of the system here and looking at interventions with intake staff around suicide prevention, Dr. Kathleen Kemp. So what about substance use? Well, a third of the sample at 14.5 years old had already used alcohol in their lifetime, and of those, 67% were using in the past 4 months. Same with marijuana or cannabis use, 48% were using in their life, had used in their lifetime. 80% of those had used in the last 4 months. This is not insignificant use. And other drug use was lower. It was 13%, again, not insignificant. But 40% of those had used other drugs. And the other drugs was very variable. It really looked more kind of like a poly experimentation group. So 1 in 7, we know young people in the system don't get their mental health needs met, right? And 1 in 10 for substance use treatment, despite those very high rates of need. So I want to talk a little bit about our approach and talk a bit about Project EPIC 2, which is the follow-up study into young adulthood now of the well, I'll explain a little bit in more detail, but the original EPIC sample that I was showing you saw at the end, it was 423 at baseline, and we followed 401 young people for 24 months, and every 4 months did an assessment with them and their caregiver. And we used eco-developmental theory, which had the individual, family, and extra-familial layers as part of the assessment, right? So we were really looking across development over time, longitudinally, 24 months, and also across the different concentric circles of their lives to understand what is influencing their trajectories of substance use, psychiatric symptoms, legal outcomes, and sexual and reproductive health and HIV and STI vulnerable behaviors. And between EPIC, from the time we started looking at findings from EPIC, we started to think about interventions for these young people. And in 2015, when I came to UCSF, after being steeped in clinical administrative work, clinical work, and being really within the systems, it became very evident that structural and system level intervention was going to be needed. And it was going to need to be community engaged, like our work with other interventions that we were doing, like family-based interventions, but at a broader structural level, and taking a social justice approach using participatory co-design methods, which I will talk a little bit about, a health equity approach, and an anti-racism approach to this work. And there's one other layer in there that I haven't added, and I'm realizing, but it's around policy and policy change, which is a separate talk, but very related. And essentially, we were missing that structural layer circle that you see there in our measurement. And we said, what if we try to find a subsample of these young people now in young adulthood and their caregivers? So that was one of the innovations of the study, like to get this kind of dyadic measurement. And what if we take this opportunity where we have this cohort in this single state where we could get a statewide structural racism index look and see what's happening for these young people and how that predicts their trajectories into young adulthood. Now they're 20 to 26 years old, and assess them once a year for 48 months, basically once a year for 4 years, adding on to look at the association of these structural level influences. And today I'm only going to have time to talk about the structural sexism preliminary findings, but we've started to disseminate some work on the structural sexism measure as well. And there's some really exciting work coming out from other scholars around the intersectionality of those two. It's all very nascent and its impact on health outcomes. So I do want to just acknowledge something too, that much of the work still around structural racism and its impact is around physical health conditions and among adults. So anybody who is interested in this space, we need you. We need to be thinking about these for young people and how we interrupt the structural pieces very early on, and actually how we think about leveraging the systems in some way to be able to do that. So I invite you all to think about that. And we will have a lot of data too. This is a plug for collaboration as well, by the way. So when we're talking about structural racism and discrimination, we're referring to the entirety of the ways in which societies cultivate and perpetuate racial discrimination through mutually reinforcing systems of housing, education, criminal legal, healthcare, employment, earnings, et cetera. This is just one definition that I adapted from Bailey et al., but there are other definitions, but it's kind of encapsulates. And these are just all the various ways in which structural racism and discrimination, the literature is really starting to come out to show the negative effects. We need those data. But what we don't know yet is what the influence is of structural racism and discrimination on first-time young people involved in the legal system, their adolescent trajectories. So those first 2 years that I told you about, like there's those trajectories of outcomes. And what are the behavioral health and legal trajectories from adolescence into young adulthood, right? Longer term, and the influence of SRD on their outcomes. And what are the early adolescent risk and protective factors? So one of the things about the eco-developmental theory, right, is we included a lot of measures around risk and protection, or vulnerability and protection, buffers, things like thinking about family factors and how school factors, neighborhood, all of those pieces may mitigate some of these pernicious trajectories that we see of substance use among these youth. So today, I'm just going to show you some really preliminary findings on the influence of SRD on first-time youth, adolescent trajectories of substance use. Okay, I want to tell you how we measured structural racism for this project. And I want to just give a shout out to my colleague, Akila Dulankita, who is doing phenomenal work with this index in the state of Rhode Island. She had a Black Rhode Island project. Oops. I said the name of the state, but you'll see it anyway. It's okay. It'll be obvious when I show you the map. But she and her colleague, Matt, have really done a lot of work in thinking about what data are available in what jurisdiction, where you are. It's really, really complex. And I don't even know if I'm going to be able to explain it so clearly in such a short amount of time. So I'm more than happy to entertain questions around it. But what you'll see is that actually I want to say there are 5 actual dimensions of the measure. It is from Mezek et al.'s 2018 study, where they used a measure with 5 domains. What we're missing here is incarceration as a domain, and I'm going to explain why that is. But Mezek et al. Found it was a police fatality shooting, found 10-point increase in this index was related to 24-fold more Black fatality shootings. And so this index has been used in other studies, and it includes segregation, education, economic, and employment. We use census tract data. Census tract data were not available when we started this project a couple years ago for the state of Rhode Island. Literally, the Prison Policy Initiative has just released census tract incarceration data. And I think this is in part because well, actually, I don't really know. We're reaching out to them because I don't really know why those data weren't available. The issue is we don't know if the data are available at the granular level that we need for within state. So we're reaching out to them because, for example, they don't have the data looking at Black versus white incarceration specifically within the state. They may be able to get it to us and we will revise this. But for now, we had to leave that out, which feels like a major limitation given our sample is also coming from being adolescent and in first-time contact with the legal system. Nevertheless, we have findings here. And I imagine that including the incarceration census tract data, if we can get those and they're appropriate for this measure, that the finding will be just that much more robust. And I want to let you know that the range is from 0 to 100 for the scale. And in the calculus that we did for the state, the range was 11 to 73. For Black versus white structural racism. And we did calculate at the bottom, you'll see an asterisk that the range was 12 to 52 for Hispanic Latine versus non-Hispanic Latine white. I'm only going to present right now the findings for the Black versus white SRI range and substance use trajectories. So here's the map. These are the yellow dots represent our participants. Remember, this is baseline when they were 14 and a half years old, where they were. And you can see here, basically, the take-home message is the darker pink, higher structural racism index for calculation, Black versus white. So you can pretty much see that very, very few of our participants were in areas that had a low structural racism index score. And we have a subsample that we're looking at for this right now because we actually had to go back and get consent for the geolocation. And so because we're still enrolling for EPIC 2, we're like rolling in that consent. But nevertheless, we have 231 young people where we can look at these trajectories. So we generated these longitudinal alcohol and cannabis use trajectories among youth who ever reported using these substances at baseline. So this is the other reason the sample size is smaller. We wanted to make sure we're just looking at youth who've already started using at baseline, which you saw those percentages early. And then we use this procedure called PROC-TRAJ, to determine latent trajectories over 7 time points that I explained to you. It was over a 24-month period. And essentially, after doing those trajectories, we conducted very preliminary analysis of the association of baseline SRD with membership in each trajectory group. So here you see the structural racism and youth alcohol use findings. And what you see here is that we have a group of non-users, which are the red. And then we have the low users for alcohol over time, 24 months in yellow. And we have a green line that's a high, consistent using alcohol user over 24 months. And I should say the y-axis is whether or not they used alcohol, yes or no. So it's proportion of use from 0 to 1, if you will, right? So you can see the non-use, obviously, we didn't include those in the association, but it's just to demonstrate what proportion, right? It was 37% who didn't use it all over the period, but then you can see the yellow, green, and blue lines, right? With the green and the blue lines being higher in terms of recent use. And so we have this de-escalating pattern in blue. So the consistent high users are the ones we are concerned about. And sure enough, higher structural racism index for these young people, it's associated with the green line only versus no use. Let's look at marijuana use. And what we see here is similar, but we've got this non-using, we don't have like a consistent no-use group. We've got these non-users, small group that are escalating. That's the yellow line, 8.4% of the sample. We've got 45% that had some use at the beginning, at baseline, and actually decline use to none. So that's low to none group. The lines that we're, again, looking at is this green line, this really high consistent use over time. And we've got this de-escalating line in blue that are still using substantially over the 7 time points, but not as high as our consistent high users in green. And what we find is that the green line, high consistent users of cannabis, and the blue de-escalating line are actually related to more structural racism and discrimination compared to no use. So these are pretty unique findings, and they're really, and we need to dig into them more, right? So we're trying now to understand them, and we're thinking about how we identify independent characteristics of these young people in relation to the impact of structural racism on alcohol and marijuana use over time. So disentangling for age, gender, race, ethnicity, right? Trauma, emotion regulation, family factors, what's going on with the de-escalating line? Maybe do they have more family support, for example, or they have other, we don't know yet, but we're going to look into that. We need to examine the impact of structural racism on psychiatric development, access to behavioral health care services, and legal outcomes. This is all for future soon. And also next, once we finish our EPIC 2 sample, by the way, it's been very challenging to find these young adults. So we initially started off with a sample of 300 young adult, sample size goal, 300 young adults and 300 caregivers. And mind you, many of them, right, are not together anymore, living together, excuse me. And we had to revise to 200. We're going to reach 200 soon, and we're doing a mixed methods design. So my colleague, Dr. Arison, who you saw, is a phenomenal qualitative researcher doing life course interviews with a subsample of these folks. So we're really going to be able to do a deeper dive into these structural racism data and look at these trajectories from adolescence into young adulthood too. And we're about to publish a paper on recruitment and retention methods for these young people. And we're going to analyze the intersectional impact of structural racism, sexism, and economic inequality across development. So I'm really hoping I'll have an opportunity to talk to you all more about that in the future. So we know structural racism is linked to all of these pieces that I mentioned before. Now we're going to start to think about intervention. And we want to do this work concurrently, because we know if we don't, I mean, we're all going to be retired, right? So... and so I want to talk about digital health a bit, because in 2015, like I mentioned, being steeped in the systems, it felt urgent at that time to think about how do we think about digital health technology to increase access to care. That was another wonderful synergistic point with Dr. Bath and her lab, where in LA and the Bay Area, we were thinking about the same things at that time, all pre-COVID, right? But it is not a panacea. And here are some scholars who talk very, very expertly about what you need to think about and caution when you're doing this work, that you must question assumptions that tech advances actually consistently benefit human health, and consider the potential gains and harms. So that's my disclaimer about this work. We take a Techquity approach to this work, which briefly is defined as the intentional design and deployment of technology, both to advance health equity and to avoid deepening existing systemic inequities and health disparities. It includes technology as well as data practices, trust in health tech, access to it, initial use or adoption of health tech, and sustained engagement. All of these pieces are critical to be thinking about. And if you remember when I talked to you about our approach, we're very kind of constantly iterating on how we're bringing our community-engaged, participatory, co-design, health equity, social justice, and anti-racism framework to this technology work. And so Clark in 2021 really has a great article where they talk about how you can bring social justice and anti-racism to Techquity by investing in people and communities, being trustworthy, very similar to the principles of community-based participatory research, community-engaged grassroots work, use AI and analytics to promote health equity. Ruha Benjamin talks a lot about that. The purchasers of tech must also drive change. And that is really like shorthand for participatory co-design. And we must develop innovative partnerships that engage diverse communities. So for those who are doing social justice-oriented research, community-engaged research, anti-racism research, this will seem like part and parcel of what you do, but the application of it to technology is not necessarily there in all the spaces. And so one of your former colleagues, Armin Arabian, who also was introduced to me by Dr. Bath here at UCLA and is now running Chorus Technologies, was our co-design partner for this project that I'm going to talk about, focusing on the intervention side of things and how we think about interventions to build access to care within systems that are serving juvenile legal and child welfare youth. And so, again, like I said, the community-partnered participatory research and the user-centered design, but it also includes the digital divide, but not the digital divide like they don't have access to devices. We're talking digital divide like bring in the people, right, who are going to be using this technology to create this technology from top to bottom, bottom to top, all around. So, and who creates matters. And so we've published various papers to really kind of think critically about this work, how we think about it across systems and how we bring together legal, child welfare, these systems to talk about technology and to build their own projects, right? To kind of be like the support for their building those. An eco-developmental framework for engaging. So I talked to you about eco-developmental theory, right, for Project EPIC. This idea of taking that framework and using it to engage youth and families into technology-based family intervention research trials. Okay, and then here are some of our various projects, and some of these are mentees projects. I want to just give a big shout out to our amazing lab and faculty who are doing work in this space. And we all work on all of these together, which makes it really fun. So I'm going to share with you about Foster Space. Foster Space, we had a generous donor who wanted to make a difference in increasing access to care for foster youth as a tool. He was very invested in reducing homelessness or houselessness. And so we met minds with him, and he generously funded us to create an app that would be an all-in-one resources, navigation, direct clinical services for foster youth. But we said, well, we are going to hire young adults and hire them intentionally as a workforce because we do not want to just give people internships, right? We want to build the pathway for the workforce. And we worked for 18 months. This was like some of the best meetings, academic meetings ever. We had co-design sessions with them for 18 months, once a week, 90 minutes to 2 hours with the developers and with the youth. And they designed this app for foster youth by foster youth. And I'm going to just play a demo for you of the Foster Space app so you can hear and learn about it.
Welcome to Foster Space, an app tailored to your mental health and wellness needs. Foster Space was co-designed in collaboration with our Foster Space Advisory Board. The FAB is made up of Bay Area foster youth who are passionate about empowering their community by making it easier to find and access the resources they need to flourish.
With Foster Space, you can take charge of your mental wellness, keep track of your mood with the Foster Space Daily Mood Tracker, take an emotional wellness assessment so your clinical care team can provide support based on your needs, or check out our catalog of wellness resources carefully selected by our Foster Space peer co-designers and UCSF care team. Foster Space is here for you. Just reach out to us via the Foster Space chat function, and a member of our team will be available to answer your questions.
Find helpful resources in your community. If local resources are what you're looking for, Foster Space has you covered. Search county-specific resources by service need. Personalize your list further by using the like function. And as always, you can reach out to one of our navigators for questions about available resources. Organize and set personal goals. As a Foster Space user, you can create missions to help you achieve your personal goals.
Feeling stuck? Reach out to the Foster Space care team for additional support creating missions. Registering for the app is easy, and we have your back if you have any questions. Register today at fosterspace.com, and you can learn more at this extension here.
So the young people that you see in the corner there, they're our Foster Space Advisory Board. They were the co-creators, and I would say largely the creators. They are the voiceovers that you hear. So we had a lot of conversations about lo-fi, like all the different sounds and the colors. They came up with the name. I mean, really is theirs. And we want to give, like, we're trying to give it to them and the systems, right? So we're figuring out that piece now. But I'm going to just, because of time, and we started a little bit, oops, sorry. Let's see if I can go. Okay. So basically what you can see is all of these aspects that the app offers. The young people were very clear. They did not want systems folks to have access to the app. So despite that we want to maybe do these systems collaborations, they didn't. So we kept it as for young people. There's all kinds of, they have videos, Adulting 101. They created all the content that's available in the app. They created these life skill educational materials that are in the app. They even did coping strategy videos. Square breathing, 5 senses grounding. And they have various testimonial videos. Is it okay if I just go over a couple minutes from the Q&A? Yes? Yeah. Okay. I just want you to see. Oh, okay. So I just want you to see from this started in 2022 and we made it available to the entire state of California. We have had contact with young people from 12 counties. We have 58 counties. I know you all know this. This is to show we only had 45 enrolled users. So you can build it, right? But will they come to use it? And we rapidly figured out, not really. The first resource that the most frequently endorsed resource that they wanted was emotional wellness services, which makes sense. That's what the app was built for. But what I want you to see here is that the app actually addresses multiple social and structural determinants of health. And that is something that we're now testing to actually see if that impacts substance use prevention in foster youth. So I'm going to just show you, the demographics. It's primarily 18 to 25-year-olds that we're using out of that 45. And we have kind of a balance of Black or African-American, white. This is how they identified on the app, and multiracial young people using it. We have a lot less. This is from the 14 who actually use navigation or telehealth services. So out of those 45, we only had even a smaller number actually use anything beyond the passive resources, right? So again, build it. Are they going to come? No. Here's what some of them said. They had very positive responses, that they felt it was calming to have someone like immediately available because they could actually have a navigator, a live navigator or clinician available. They needed help identifying emotional wellness resources because of their insurance. Again, another structural barrier. And so now I'll close by saying we've just been funded by NIDA. And this is kind of where all of the pieces are coming together on that path to do an implementation science trial of foster space with court-appointed special advocates. So court-appointed special advocates, there's a program in actually 54 programs in the state. They work one-to-one. They're a volunteer advocate assigned to a foster youth. They typically meet one time weekly, and they have average length of time with the youth in the state of California. It's a national program, but in the state of California, it's usually for about 12 months. Some have been with them for multiple years. And there are 11,000 active CASA volunteers in this state serving 13,000 children and youth. It's an enormous opportunity to build capacity in a system to change the system, right? Because for those of you who may not know, CASA workers are predominantly white and not necessarily near peers, if you will, to these young people. And they are highly committed, and they are being asked to be mental health experts, substance use experts, family experts. So this is an opportunity to kind of think about how to build capacity, and the trial is going to enroll youth and CASA volunteer dyads. The youth has to be between the ages of 13 to 20, and they have to live in California. And the first phase, we've been partnering with Contra Costa County to do a little bit of substance use prevention adaptation to the app, but very minimal, because what we want to see is the social determinants of health component and whether that's actually going to reduce substance use among these young people. And then we're doing a clinical trial with 10 counties across the state of California, which will start next year, in which we're randomizing the CASA volunteers to get more intensive, like Project Echo, like a telehealth model training in substance use prevention, or a one session, like 101. And we want to understand what's the reach and effectiveness and adoption of foster space, but within CASA programs. So if we provide trainings for these volunteers on substance use prevention with foster youth, will those randomized to receive those trainings have foster youth who are more likely to use it, right? And does it actually reduce substance use for young people in the foster care system? So hopefully I can come back and talk about some of that as well. But thank you. I really appreciate the time and look forward to questions. There's nothing in the chat. Just so you know.
Are there another question here?
Oh, there's the Q&A. Yeah. Okay. Should I escape from here? I mean, not escape. That's out of my Should I escape?
Escape from some Q&A.
Okay. Do you want to? Do we have to read the? Do you want to read it, or do you want me to?
I mean, yeah.
Okay.
I think you got this. Hey.
Do you consider prenatal exposures, multiple placements, family stressors in evaluating substance use outcomes and effectiveness of interventions? Thank you so much for this question, Mary. Multiple placements, family stressors, we absolutely consider. We actually have caregiver report of those as well as the youth report. So there's opportunity. One of our fellows is looking at actually discrepancies of reporting in some of these areas to see how that actually mitigates or promotes vulnerability for use over time. The prenatal exposures, we don't directly assess, although I think we ask the caregivers about we do ask them about developmental history but not a thorough, and it's also self-report. So those data, but we should be. Yeah, thank you for that. Are there any projects to improve and strengthen families? The absence of fathers has been correlated, with higher criminal behavior in children, for example. What about partnerships with religious organizations for spiritual interventions? Thank you for that question as well. So the same fellow who I was just referring to actually has had a father's project at UC Santa Barbara with Mia Barnett in terms of parent-child interaction therapy. And we've been talking about ways in which he might start to think about father interventions for young people in foster care and legal system. So there's a dearth of research and interventions in that area, and we would be thrilled to collaborate with anybody interested in that space. And also your question about religious organizations for spiritual interventions. I so appreciate this question. So we have been, but indirectly. So we have been partnering with community organizations, one recently called 100 Years of Those with Living Experience, who are partnered with the church or the religious organizations. And their name is the 100 Years Enterprise because across the three of these men, I've looked them up online, they're an amazing organization, but across the three of these men, they have 100 years of incarceration time together. And they are the only direct contract with Contra Costa County Probation to go into the hall there to work with the young people, being credible messengers, and also they're teaching like emotion regulation, and and there's a very spiritual component to their work. So we're starting to collaborate with them. I don't know if that answered it fully, but
thank you for your
Dr. Hansen
path-breaking work. This is just
thanks,
astounding work. And you brought up an interesting tension at the end with the foster app, which was the distrust of these systems, multiple systems on the part of the youth, understandably so.
Yes.
I'm sure, if I had to survive for a few days as a foster youth.
Absolutely.
I've got the same distrust of systems.
Yes.
And that's an interesting bridge to divide if you're trying to address structural drivers of health.
It really is.
And so I wonder if you could comment a little bit on that, the way that youth, many of the youth, whether they're in foster care or not, are thinking about systems, relating to systems. So I think these interventions focused on that aspect of it, the way that they relate to think about systems.
Such a great question, and I'm so excited you asked it because this has been the conversation in our lab lately, because as I mentioned to you, we want to build the pathways for the young people as well. So actually we have since hired one of our FAB members as their full-time team member as a research assistant, but they're also continuing to be part of the Foster Space Advisory Board, and they're working on this project, and they were a CASA youth. And so we have been it's just been coming up because we had a CASA advisory board for this first phase, which I didn't even get to talk about. That young person was in the space with us, right? And so as we are debriefing around this, it is ripe for a next step intervention. And we're trying to figure out how to do this in a way that the young people feel safe. There have been many things that have been very triggering for them, even in the meetings. And this is within a system. The CASA programs, this is my first introduction to working with CASA. It's really a different system because they're all volunteers and they're all wanting to help, but they're not even under, they need so much support themselves. It's not anything. And so we're thinking about how are we going to actually be educating the system from a young person's perspective. I could go on, and I would love to talk with you more about that, but it is a significant tension. And I don't think people can know that tension until you're actually doing that work. You know what I mean? And having those with living experience being integrated into the team. Yeah. Thank you for that question. Hi.
So I had a question about, like, you mentioned geolocation, and you know I do like super like techie
Yes.
research. So I was wondering,
Way beyond me.
no, so I was wondering, like, when you're looking at like the structural racism index, and like, are you looking at how these like youth have moved through like time and space over the time that you've been following them,
Yeah.
or is it like a static, right? Like,
I feel like you all are planted in our lab meetings because I need to actually have you come to help me answer these questions.
Right? Because I think it'd be super cool to look at, like, you know, like people move over time.
Absolutely.
How do like these kids move over time? But like, where do you live? You may be exposed to different things.
Absolutely.
And, like, where do you go to school?
So this is
where they spend most of the
absolutely.
time. And so,
oh, sorry. I have to repeat, and I didn't repeat
Helen's question. This is like ending up to be a very long question, but right. So like, I would imagine that like with all the cool data that you're collecting, that you can see that if trajectories of how you're moving through time and space over like a prolonged period of time, you may actually see differences in how those like social determinants of health actually impact like health outcomes.
Yes.
And so even though you like a group of kids all like reside in the same like zip code, let's say, if they have different trajectories over time moving through other zip codes, their like trajectories actually probably look different.
Yeah, absolutely. And I'm sorry, I did not repeat the question, but the question was basically, if you have, do we have opportunity to think about where these young people move in terms of time and space and exposures, using wearables or technologies or these pieces to actually look at how those structural factors impact, right, their outcomes. And then I just want to say Dr. Hansen's question, for those who didn't hear it and you heard me answer, was around how do you resolve, or how do you think about, or is there opportunity to study that inherent tension between having the young people who have designed the app and want the app for themselves and their experience with the systems that are often very challenging and can be negative, and what comes up around that, and what do we need to think about studying that tension for it to be successful, for those interventions to be adopted by the systems. So just an answer to Dr. Baggett's question about so we do not have opportunity, obviously, to go back to the adolescent trajectories. We do have opportunity for a supplement potentially to do this for moving forward, and we could talk about that. That would be great. And I think it could be a really important scientific opportunity. What I will say, though, why I said, were you at our lab meetings, because we have gone back and forth and around the bend about at what address actually do we use in these longitudinal analyses. And so because we are first interested in understanding that first time legal contact or court contact opportunity for intervention, we thought, okay, let's just start there, at least with their baseline location, because we're also presuming 14 and a half years old. It's a smaller state. A lot of them, it said, like we can actually look to see how long they've been in school there, that sort of thing. So we imagine that they've been there for at least some decent period of time at baseline. So we thought that was a place to start, but this is going to like be we've got to figure out what we're going to do and how we're going to do it rigorously, plus the supplement idea.
There may be another question underneath, but I'm not sure.
Oh, sorry.
Yeah.
Oh,
Dr. Asana.
Yes. Okay.
And this could be our outro.
This is our outro, yeah, because we're over time. Okay. Oh, thank you, Dr. Sarno. Okay, what a wonderful program of work. Your development of your technology intervention is an impressive example of co-design. Even with your elegant co-design approach, your use is low, exactly as we're finding with many tech interventions. You have added a human touch by including CASA workers. If you have unlimited funds, how might you use technology to improve care and support while not running the risk of shifting vulnerable participants to technology-based services versus support and care delivered by a person? Oh, such a good question. Thank you. I mean, outside of like, if I had unlimited funds, that's really, but so what I would do, I had no idea until we started engaging in this work with CASA volunteers in particular, because all of our work's been like with probation, with the courts, like all of those stuff. I had no idea how receptive and how much like these volunteers would be to learning and wanting support, and how much there's just such a huge gap. They initially, when we started the advisory board with the county, it was, we don't really, substance use, yeah, we don't really talk about it. Now we've been piloting our open trial of our echo telehealth models with them. And the end of the sessions, they're saying, oh my God, this was like, I didn't know what I didn't know. And so if I had unlimited funds, I would actually use technology potentially for the CASA volunteers in particular. And I think the foster youth don't want them in the same app, right? But the CASA volunteers do, right? They want to be able to. So, and we've talked about this a lot with Dr. Beth about these cross systems interventions using technology to support them, to support the youth. So they still have the in-person supports, but they're getting a coach, right? Or they're getting some bug in the ear, if you will, through the technology. So I really appreciate that question because again, it's nowhere near a panacea. Lots of limitations to consider. Thank you for that. Thanks for having me.